And thanks, Dr. Kirkwood and AIMatMelanoma for having me speak today. As Dr. Zaror pointed out, I'm going to be talking about a pretty different topic for the next 15 minutes, which is the prevention of melanoma. And I'll explain what this term therapeutic prevention means in a couple slides. So why do we care about melanoma prevention? In this graph, you can see that melanoma is the 5th most commonly diagnosed cancer in the United States, and the number of new diagnoses is increasing faster than pretty much any of the other common cancers. So clearly there's an issue there. And if you asked me on April 4th, 2020, what can I do to prevent myself from getting melanoma, I would recommend the traditional recommendations, which are applying sunscreen, wearing sun protective clothing, avoiding excessive sun exposure, and getting routine skin exams with a healthcare provider. But clearly, on a population level, those have not been enough to slow this rising number of melanoma diagnoses. So to figure out what we could do better, one approach that might be helpful is to look at what's worked in other diseases. So, for example, in heart disease, everyone may be aware heart disease and cancer have been the top 2 leading causes of death for many years. And this graph shows really a remarkable decrease in deaths from heart disease in both men at the top and then women over the past several decades. And as much as 50% of this improvement has been thought to be due to something that we're calling therapeutic prevention, which is the use of medicines to prevent, slow, or reverse the onset of disease. Now, in heart disease, what these are is medications like blood pressure medications and medications for high cholesterol that are very well established in clinical practice. So why hasn't this been more successful in cancer? I'm going to list a few issues here and potential solutions. First of all, cancer is a very complicated set of diverse diseases, really. And our understanding of what causes cancers to develop has really lagged behind our understanding of heart disease. Fortunately, there have been a wealth of advances in both knowledge and techniques to study the development of cancer that are helping us address this problem better moving forwards. Second, cancer develops over many years. And in order to prevent cancer, patients may need to take a medication for many years. So in order to balance the benefits and the risks, we have to basically develop medications that are inexpensive and minimally or non-toxic. So the way people have addressed this so far is by using existing medications that are old, inexpensive, and have extensive safety history. And people have also used things like vitamins or diet-based chemicals. The other important piece of this is focusing on treating patients who are at higher risk of developing cancer so that the potential benefit will outweigh any risk or inconvenience that they might experience. Finally, and this sort of relates to the second point, there's a relative lack of interest from big pharmaceutical companies because these medications almost have to be inexpensive and easily available. Pharmaceutical companies are much less likely to witness huge profits from developing these agents. So what that means is to run these studies, we rely on funding from the government and from philanthropy money for this important research. So for the rest of the talk, I wanted to briefly go over just a survey of 3 topics in therapeutic prevention of melanoma. First, I wanted to talk about what patients might benefit the most from preventing melanoma. And to look at this, I wanted to start with just a brief figure of how melanoma develops from normal benign skin cells to benign nevi to more atypical looking nevi, and then sort of localized melanoma, and then finally invasive melanoma that invades into the skin and can spread elsewhere in the body. In reality, there's frequently not such an orderly stepwise progression, but it's still helpful to, this figure is still helpful to discuss. And important parts of this are that a lot of this early process is driven by ultraviolet radiation from the sun or tanning beds that causes progressive damage to the skin cells. And it's just logically makes sense that patients who've already had a melanoma probably have other areas of their skin that are intermediate in this process and are at risk for developing another melanoma. The other feature of this that I wanted to talk about was this intermediate neoplasm, or atypical nevus, as Dr. Kirkwood sometimes calls them, funny moles. And these can sometimes progress to melanomas. It's estimated that 20 or 30% of melanomas develop from atypical nevi. And patients who have multiple atypical nevi are at higher risk for developing melanoma. So to put all of this together, patients with both a history of prior melanoma and multiple atypical nevi have about a 9-fold risk greater than the general population of developing another melanoma. And we feel that these are appropriate patients to target in terms of cancer prevention. Another point that I wanted to mention here is that the atypical nevi provide something that we can study. We can look at features of atypical nevi before and after drug treatment and try to see whether the drug is working. So we are working with a couple companies to develop innovative technologies to look at atypical nevi. There's a company called Vatel that has designed this very interesting image analysis software that can take images of individual nevi or even a patient's whole back and correct for different lighting, different patient positioning, or even changes in the patient weight, and also identify the nevi in an automated fashion and compare features of different nevi over time. So this allows us to perceive changes that might be impossible to notice just in a routine skin exam every several months or every year. The other technology that we're excited about is developed by a company called DermTech, and it allows us to non-invasively assess the gene expression in atypical nevi over time. What this involves is applying adhesive tapes to the lesion, stripping them off, and in that process, some of the genetic material is removed and can be analyzed in the lab. A very specific version of this assay has been shown to be of benefit in the diagnosis of melanoma and is now entering clinical practice. So we're hoping to expand this technology to look at other genes and how they change with treatment. So the second topic I wanted to talk about briefly is a specific drug that we're looking at for therapeutic prevention of melanoma. It's called sulforaphane, and it was isolated when people noticed that patients who ate more broccoli or other cruciferous vegetables appeared to have less cancer. And this led to the isolation of sulforaphane, which could plausibly be behind some of these effects. And sulforaphane has been studied in a large number of cell and animal models, and in some early human studies. It's now in a number of human clinical trials to prevent various types of cancer. There's specific evidence, early evidence, that it could be effective in preventing skin cancer. It not only alters the response of the skin to ultraviolet radiation, but it also potentially has effects on later processes in melanoma development, including invasion and metastasis. So you may be asking yourself, why don't we just eat a lot of broccoli? Why do we even need this research? And there are a couple points I want to point out. First of all, the mature broccoli actually contains relatively little sulforaphane. It's mostly in these 3-day-old broccoli sprouts, which are not a usual food. Now, granted, there are a number of companies manufacturing concentrated versions of sulforaphane as nutritional supplements, but the main point I wanted to bring up is that we really need clinical trials to demonstrate that this drug and other preventative drugs are actually helpful. There have been a number of examples of drugs that showed promise for cancer prevention, but then when they were studied in large enough human trials, they did not have the effects that people expected. So I definitely want to echo what a number of other people have said today about the importance of participating in well-designed clinical trials and, probably only using experimental compounds like this in that context of clinical trials. So speaking of trials, I wanted to mention briefly an early phase 1 trial of sulforaphane that Dr. Kirkwood's group did actually before I came here. In this patient population I was talking about, patients with a prior history of melanoma and multiple atypical nevi, 17 patients were given different doses of oral sulforaphane for a month. And what was found was that this medication was non-toxic at all doses. It reached the skin in levels that plausibly could affect the pathways that had been seen in earlier studies. And there were some preliminary signals of clinical effect, although I should point out that this trial had too few patients and was too short to really appreciate a helpful effect. So because of that, we're planning a much larger trial in about 100 patients who will be treated with either sulforaphane or an inactive placebo pill to compare and see what really sulforaphane is doing. We're going to treat people for 1 year to better observe the changes over a longer period of time. And we're going to use the innovative technologies that I mentioned previously, as well as traditional methods to evaluate changes in the atypical nevi. We're planning this to be organized at multiple clinical sites through the Eastern Cooperative Oncology Group, and I hope that this will be running in the not too distant future. Finally, I just wanted to talk very quickly about a project that we have in very early stages. We've heard a number of times today about the great power of the immune system to treat melanoma, and it certainly begs the question, could it be useful to prevent melanoma also? And there's evidence that it can be, but I just wanted to share one quick single case report that was pretty striking in the context of everything else I'm saying. There was a patient with melanoma that had spread throughout the body who also had these multiple atypical nevi. You can see a picture of his back here. And he was treated with nivolumab, which is an immune checkpoint inhibitor, which, as many of you know, sort of releases the brakes of the immune system and helps it attack the melanoma. And remarkably, not only, he had essentially complete regression of most of his atypical nevi. More importantly for him, he also had disappearance of basically all of his melanoma disease. So it seemed like the response of the atypical nevi correlated with the response of his melanoma. And, this suggests that, there may be value in, immune therapies that target atypical nevi and also melanoma. So one issue, though, ipilimumab is expensive. It does have side effects in some patients, so it's not really a practical agent for prevention of melanoma. So we're thinking of possibly using the tried and true method of activating the immune system, which is vaccines. These have been notoriously unsuccessful in the treatment of advanced cancer, but we are excited to work with a collaborator, Dr. Olia Finn, who's sort of the preeminent figure in developing vaccines for the prevention of cancer. And her theory is that, if we use vaccines before cancer has evaded the immune system, this may be much more effective. And I'm hoping that, certainly if we present this topic in future talks, we'll have a lot more details to talk to you about this project.